Good evening. It is 1st May, 1st of every month, and we are back with the academic activities. Today, I have to say Jai Maharashtra because it is a Maharashtra Din. And the importance of vaccination is well known to all of us. We all are vaccinating children, adolescents, young adults who go overseas, and recently to geriatric community as well. In addition to this, we have to be well versed with the vaccination strategies for travelers, as it is having two aspects. One, for the vaccination for the index child, where we are vaccinating the child. But the second important thing is when he go back to his own community, whether the community is safeguarded or not. This is nicely studied in first article. Our second research article is about status epilepticus and a study comprising two drugs, which is very helpful for the pediatricians of periphery. We are having well experienced experts as well as presenters for this episode, and I immensely thank our Maha IIP President, Secretary General, and Raigad IIP President, and our editor, Dr. Neha Singh. I once again welcome all of you, and I ask Dr. Neha to proceed for the formal introduction of the speakers and presenters. Dr. Neha, please.
Thank you, Chitra ma'am. Good evening all. Myself, Dr. Neha Singh, on behalf of Maharashtra IIP and Raigad IIP, welcome all the respected dignitaries, seniors and colleagues for today's journal journey. I welcome Maha IIP President Dr. Ram Gopal Chijara sir, Amol Pawar sir, as well as all the respected executive board members of Central IIP and Maha IIP. I also welcome Raigad IIP President Dr. Vikas More sir, Secretary Dr. Ajay Kohli sir, and our patron respected Dr. Neeman Mohanty sir, Jay Bhandarkar sir, Dr. Chitra Kulkarni ma'am, and all the members from Raigad IIP and other branches. Today's session has been granted 1 MMC points, so requesting everyone to type their name, MMC number, Central IIP number, and city in the chat box. Today's session of Journal Journey, we have with us Dr. Prashant Vadane, pediatric cardiologist practicing at Nashik, as our MMC observer for today. And for today's session, we have two experts with us, Dr. Sanjay Marathe sir. He is director of Colors Hospital and Marathe Children Hospital, Nagpur. Sir has given his contribution in IIP guidebook on immunization, the Purple Book. And Dr. Umesh Kalane, pediatric neurologist and epileptologist at Dinanath Mangeshkar Hospital, BJ Medical and Bharti Vidyapeeth Hospital, Pune. And our two presenters for today are Dr. Balkrishna Chaudhary, consultant pediatrician and neonatologist. He is working as assistant professor at Sri Vasantrao Nayak Government Medical College, Yavatmal. And he will be presenting the review article, Vaccines for International Pediatric Travelers. And our second presenter is Dr. Nitin R., MD Pediatrics, currently doing fellowship in pediatric epilepsy and neurology at Bharti Vidyapeeth, Pune. He will be presenting the research paper levetiracetam and midazolam versus midazolam alone for first-line treatment of children with generalized convulsive status epilepticus. Now I request our first presenter, Dr. Balkrishna Chaudhary sir, to kindly share his presentation. Over to you, sir.
Thank you, ma'am. Thank you very much. Good evening to everyone, and thanks for giving me this opportunity. So today we are having a review article from the Pediatric Clinics of North America Journal, which is published in May 2020, which is about the vaccines for international pediatric travelers. The impact factor of this journal is 2.7. Now, discuss why we are discussing this article. That is important. So what tourism data says, this article is published in US journal. So they are saying that in the US 2.4 million children travels per yearly. And according to our Indian statistic data, around year 2020, 40 years age group contributes about 4% and 15 to 24 years contributes about 14% of total traveling population from India, and this population is day by day increasing. Secondly, the awareness regarding the pre-travel consultation. As pre-travel consultation awareness is very much low. One cross-sectional study was also published in Europe, which noticed that the only 52.1% of responders had sought travel advice before the traveling. And there are recent so much health emergencies within these 10 years, that is Ebola, chikungunya, then multi-drug resistant typhoid, tuberculosis, COVID. So it is the need of our to discuss this topic. So what we are going to see in this review article, the preparing patients for the travel, then general principles regarding the travel immunizations, routine vaccines, recommended vaccines, and required vaccines. So preparing patients for travel, it includes the performing an individual risk assessment. Individual risk assessment, it includes the patient, whether has suffered any previous diseases or he is having any any allergies to the vaccine or any disease or on any medications, then communicating the destination specific anticipated health risk, where they are traveling, how much time they are going to live there, and what activities they are going to do there. Then managing the health risk by providing the risk mitigation strategy. This is also important if they are going to expose any endemic areas, which is for the malaria or typhoid, then the advice should be given for proper personal protective measures. Then the component of risk communication, then anticipating the risk for the insects bites, then sun exposure and food water contamination. These all should be mitigated. In composition of components of mitigation of risk, it involves the chemoprophylaxis for travelers diarrhea and malaria. Then general principle regarding the travel and immunizations. The traveler specific immunization is very important. Traveler specific immunization means the age of the patients, then the what vaccination he has previously received, or what vaccinations are remaining to be given, is there need to be accelerated. Then destination specific immunization. Some countries destination specific immunization where they are going are that area is endemic for some diseases, that is also important. Then country specific vaccination recommendations. Some country demand the special vaccination certificate to entry in their country. In that situation, that vaccination should be completed. Then in routine vaccines, the routine vaccines are those vaccines which are recommended by Advisory Committee on Immunization Practices. This includes, first we are going to discuss the routine vaccines. The routine in that measles, mumps, rubella or measles, mumps, rubella, varicella vaccines. What they recommend that all children aged 12 months or older should receive 2 doses of MMR vaccines, and infants 6 to 11 months should receive the single dose before routine recommendation vaccine. And whenever they come back to their original country, they should get a second dose, because the vaccination done before 1 year, that immunity is not going to long last. Then third, the adolescent who have no evidence of any immunity should receive 2 doses of MMR or MMR-V vaccine, which should be 28 days apart. And measles, mumps, rubella, varicella vaccines can be given up to 12 years of age. Then the second vaccine we are going to discuss is the vaccine varicella. The travelers are at higher risk for severe varicella because it is the most infectious disease and it is also vaccine preventable. The travelers who are risk are the immunocompromised, who is on chemotherapy or HIV positive or any other drugs, immunomodulator therapy, they should receive these varicella vaccines. The all children aged 12 months or older should be vaccinated, and children should require 2 doses. The first dose should be given at 12 to 15 months of age, and second dose aged 4 to 6 years. If the second dose is administered after 7 years and before the 13 year, the interval between these 2 doses should be 3 months, and if it is given after 3 years, the 4 weeks interval should be there. Then third, it's also most important part, which is transmitted by virus, influenza, and it is also the vaccine preventable. What they recommend in this review article, the child more than 6 months age should receive 2 doses separated by 4 weeks, and the risk of acquiring influenza depends on the geographic variation and geographic type or subtype also influenza. The northern hemisphere, in northern hemisphere, in month of May to November, it has the infectious period of influenza, and southern hemisphere to October to June, it is infectious period. So the vaccination should be given to this child before 4 weeks before traveling. Then regarding the polio, WHO has declared it as a public health emergency in May 2014, what they have advised that the traveler who is living in the wide polio virus circulating country should get the vaccination done, and they recommend 4 doses for this IPV inactivated polio virus vaccine at the age of 2, 4, 6, and 18 months, and at 4 to 6 years. If the last dose has received more than 4 years of age, then and last dose should be received more than 4 CF age, and if not, it should be received more than 6 months from the previous dose. The polio vaccine should be given 4 weeks and 12 months before departure from the polio affected country, which are mostly the Pakistan and Afghanistan. Then third recommended vaccines is the typhoid vaccine. The typhoid is the most infectious caused by the Salmonella typhi. Its early stages is present as a fever, malaise, then abdominal pains, and in later stages it can pair with abdominal hemorrhages, then coma and death. So this is very important to tell the traveler about the traveling region also. If that region is endemic for the typhoid, they should maintain the food, water, and safety. That is also important. Then the vaccination, they are advising typhoid vaccination should be recommended for children more than 2 years, and they are recommended 2 vaccines. One is VI capsular polysaccharide vaccine, and secondly typhoid 21A oral vaccine. So the single dose of 0.5 ml dose intramuscular should be given of VI polysaccharide capsule, and the primary dose should be given more than 2 weeks before a travel. A booster dose for every 2 years for children who remain at risk should be given. Then TY21 oral vaccine, it is a live attenuated vaccine. It is recommended more than 6 years old, and 4 capsules should be taken every other day, and 4 doses should be completed more than one before exposure. The efficacy of both these vaccines lies to 50 to 80%. So it tells the stress on the sanitary measures, food measures, and water safety measures. Then the hepatitis A, it is also most infectious disease, and it is vaccine preventable. It is spread by the fecal-oral route. So indications for vaccination of hepatitis A, they are in routine immunization schedule. What they have advised at 12 to 23 months, they should receive a 2-dose series, and 2 to 18 years. If they are unimmunized previously, should receive the single dose. If between the 6 to 11 months, single dose 2 weeks before departure should be given. And children who are less than 6 months or immunocompromised children should receive the hepatitis immunoglobulin. Then the vaccine administration, 2 doses with minimum interval of 6 months should be given, and the immunoglobulin they are advised is the GAM stand. It depends on the duration of exposure, how much time they are going to live there in the endemic region of hepatitis A. If they are living for the 1 month, the dose should be 0.1 ml per kg. If they are living for 2 months, then it should be 0.2 ml per kg, and it can be repeated 2 monthly. The mechanism of action, it half-life is immunoglobulin G is start to form, and it lies up to 21 days in the body. Then if in case the MMR and hepatitis A vaccines given simultaneously, in that case the MMR should be given 2 weeks before the hepatitis A virus immunoglobulin. And if hepatitis A virus immunoglobulin given less than 14 days after the MMR, then MMR should be repeated after 6 months. In the post-exposure prophylaxis, they are advised the hepatitis A vaccine or immunoglobulin should be administered less than 2 weeks before the after the exposure. The after the exposure. This is about the hepatitis A. And in case if simultaneously hepatitis A and immunoglobulin should be administered in any individual, in that case it should be administered on separate extremities. Then the rabies vaccine, it is also most important disease which is transmitted by the animal bites, and it is 99% endemic is in Asian countries, then South America's countries. The pre-exposure immunization, they advise population of traveler at risk are these peoples who are working as hikers, sprinklers, and then who are working in the bat and animal conservation industries. They should receive the pre-exposure vaccination. The 3 doses they have had 3 intramuscular injection on 0, 7, 21 or 21 days in the deltoid. It contains a human diploid cell culture vaccine or chick embryo cells vaccines. Then before travelers should complete 3 doses of pre-exposure prophylaxis. If during the trip they came through the animal bite, in that case it should receive 0 and 3 days with no immunoglobulin. In the post-exposure prophylaxis, they advise 4 rabies vaccine doses on days 0, 3, 7, and 14 days. And they also advise 5th dose for immunocompromise on 28 days. Then the Japanese encephalitis, it is also most important infectious disease which can be preventable by vaccines. So what they advise is Japanese encephalitis, the travelers who plan to spend more than 1 month in the endemic region should receive the vaccination, and who are staying less than 1 month. That depends on many factors such as season, activities, and these activities might include camping, hiking, trekking, biking, fishing, hunting, or farming. Then vaccines administration in US, they are giving the varicella culture derived JE vaccine, this is XARO, and it is the only licensed and available vaccine in the US. It's approved for 2 months and older children. The 2-dose series should be completed with the doses spaced 28 days apart. The last dose should be given less than 1 week before the travels. The adult and children who require third dose at 1 year more after completion of the primary XARO series, if there is ongoing exposure or re-exposure to JE virus is expected. Then the required vaccines, these are recommended by CDC. These includes the yellow fever. Though yellow fever, they are recommending yellow fever vaccine for children aged more than 9 months. It is contraindicated in immunocompromised childs, that is having the primary immunodeficiency, or transplant recipients, or patient in immunosuppressor or immunomodulator drugs, or patient who are having HIV with CD4 count less than 200 per ml. Then after this vaccine has also two adverse effect following the immunization. One is virus yellow fever associated neurotropic disease, which present as a acute disseminated encephalomyelitis, meningoencephalitis, Guillain-Barré syndrome, cranial palsies after receipt of the yellow fever vaccines. And second is yellow fever vaccine associated viscerotropic disease. It occurs 4 days, ranges from 1 to 18 days after the 4 days of vaccines. It presents similar to wild type of yellow fever disease, but causes multi-organ failure and death. Then the meningococcal vaccine, it is caused by gram-negative Diplococcus organism, and in specific regions, sub-Saharan Africa and Saudi, they are going to cause the outbreaks. Mostly these outbreaks are caused by serotype A, and there are less outbreaks by serotype B. What they recommend, single dose at age 12 to 11 to 12 years, and booster at 6 to 18 years. The high-risk children who is having terminal complement component deficiency or functional anatomic asplenia or a HIV positive, they should receive the meningococcal vaccines. The traveler traveling to meningitis belt of sub-Saharan Africa and traveler to Saudi Arabia during the Hajj should receive the vaccines. In Hajj, they had told that the serotype W135 has recently caused the outbreak. So vaccine administration in US, there are 2 formulations, 3 formulations are available. These are quadrivalent meningococcal vaccines. These are main ACVWYD, main ACVWC, main ACVWYTT, and so in children who are previously vaccinated should receive the booster, and children who have completed the primary series less than 7 years age, booster dose of main ACVW after 3 years and repeated every 5 years thereafter if they live in or travel to hyperendemic areas. For infants less than 9 months, they advise main ACYW CRM 4-dose series at 2, 4, 6, and 12 months. In children 7 to 23 months of age, same vaccine for 2-dose series, and 9 months to 55 years. They have advised a single vaccine. Then again, next vaccine about the cholera. Cholera is also so much infectious in endemic regions. It is transmitted by the water contamination. And in presently at US, there is only one vaccine is licensed, but it is not also available at present, which is CVD 103 HGR, single dose oral cholera vaccine, Vaxchlora, and it's approved for 2 to 64 years for single dose. The instruction is for that the eating or drinking should be avoided for 60 minutes before and after oral injection of Vaxchlora. Vaxchlora should be taken at least 10 days before the travels. And the advantage of this vaccine is Vasclora may shed in the stool for at least 7 days, and the vaccine strain may be transmitted to non-vaccinated close contacts, which can cause herd immunity. So these are the all three vaccines, routine vaccine, recommended vaccinations. Now we are going to see about the timing and spacing of immunobiologics. The vaccination schedule, it can be accelerated rather than if there is a recommended vaccination schedule is there and patient is going to travel, we can accelerate the vaccination, or the vaccines can be given 2 weeks before the travel. In all the required vaccine can be administered as same visit with a few exceptions. And then MCV4D, Menectra, and PCV30 should not be administered simultaneously. In child that requires both PCV30 and PPSV23, the PCV30 should be administered before, and PPSV23 should be administered after 8 weeks. The all live vaccine can be administered simultaneously: MMR, varicella, live attenuated influenza, yellow fever, and oral typhoid. In the live vaccination schedule, the duration should be mentioned in between 2 doses. It should be 4 weeks or 28 days. Then tuberculosis skin test can be done after the live vaccines on same day or after 4 to 6 weeks. Now, summarizing this all review article, what we can think of: care of the traveling child is very important, considering the pre-illnesses, then allergies for vaccinations, and whether the patient is on any drug. Then children at the risk of traveling, the age group of children is matters. Then the protecting the travelers during the trip, that telling that they are wearing personal protective measures, and a routine childhood vaccination should be completed earliest. Thank you. Thank you very much.
Thank you, doctor. Can you stop share?
Yes, ma'am.
Yeah, over to expert, Dr. Sanjay.
Yeah. Thank you for the opportunity, Maharashtra IP, DIP platform. It was always a pleasure for me, because last year also we had almost 12 episode series on immunization. And I think it was quite effective for all the pediatricians who are practicing. Thank you, Dr. Chejara, Dr. Amol, Dr. Chitra ma'am, and Dr. Neha, and everybody who has come on 1st of May, that is Maharashtra Din. And I can see almost 200 people already joined, and there might be a few more on the YouTube. That tells indirectly that they are still interested in vaccinology and different issues, because every day you face this problem. Thank you, Balkishan, for an excellent presentation. You have covered almost all the points fairly well. And a couple of things which I would like to add as an expert, that travelers have become such an important entity. Everybody who is sitting in the audience must be visiting some or the other country once in a year. Not only that, there are so many people who are coming from other countries to our country. Then, as he has rightly said, newer and newer infections are coming up. Zika virus, chikungunya, COVID vaccine, and we are learning some new things every time. Even for the flu, we must know what is the southern hemispheric vaccine, what is the northern hemispheric vaccine, because you have to give advice to them. So you should be updated every time. What kind of an advice you should give to your usually parents of your patients, or the students will come for the education. They are going after, say, 17, 18 years, and June and July, usually these are 2 months where you get maximum number of patients coming to you to fill up the forms and all that. So you must know what kind of an advice you should give. So as far as the traveler's immunization is concerned, you have to protect the individual who is going abroad for some time, not for a short duration of few days, from the vaccine preventable diseases, but also to the community when he comes back. That is equally important. Very unfortunately, it says only 50% of the people have taken your advice. It requires more and more sensitization. They are not aware that you have to take some vaccines. Even our pediatricians are not aware. Unless they get some communication from that university or something, you start reading. Acha, aisa bhi karna hai, 2 MMR dena hai, 1 MMR. Then you start writing, acha, you have to give this vaccine also. What we should know, that what are the vaccines we should give as a protection. Not only the vaccines, some medicines sometimes you have to give. Like sometimes you have to give malaria prophylaxis. Sometimes you have to say how you can prevent yourself from the mosquito bites. Many people are going for hiking, they are going for mountaineering. Somebody will go and accept a job somewhere, or either in the deep forest he is working. So there are so many situations where you will have to give advice accordingly. My suggestion to Dr. Krishna, because it was in his that article, what has happened, he has given you all the CDC guidelines, and it will confuse all the pediatricians who are sitting here, because our immunization schedule is different than theirs. So my first suggestion is, do not follow the CDC guidelines blindly. They are very useful because they are scientifically based, but they may not suit our country's immunization schedule. So whenever you give an advice, because we want to know what is the immunization status of an individual according to our immunization schedule, not according to the CDC immunization.
Yes, sir.
That is one. So your suggestions will go accordingly. Now, suppose we say a couple of things. I always think there are few vaccines where you have to give them a very specific immunization advice. I was just taking few points from your presentation. So like you said MMR. MMR, if it is given from at around say 6 months of age,
Yes,
it is not to be counted.
Yes, sir.
And again you give 2 doses after 1 year.
Yes.
So that vaccine is given as an, usually there is an outbreak or something, or you are going to an area where there are many cases of measles. So you protect that individual, but immune responses, we are not very sure. So you give that dose as an additional dose.
Yes.
That is one. You said chickenpox vaccine. Our recommendation is second dose is to be given after 3 to 6 months.
Yes.
Initially, we used to give at 4.5 years. So audience who are listening, they will say second dose to be given after 3 to 6 months. And after 13 years of age, the minimum gap can be 4 weeks. So somebody is traveling, say he is going to America for a job or something, and he has never been given any chickenpox vaccine. And now time allowed is only 1 month with you. You can give 1 dose, and then after 4 weeks, you give second dose and give him a certificate. So this is an advantage. For the flu vaccine, see, you must know what is the change in the northern hemispheric vaccine from the southern hemisphere. Friends, this time there is no change. So throughout the year, you can use the same vaccine for next 1 year. But usually what happens from the northern hemispheric vaccine, this time the southern hemispheric vaccine, there is one change in H3N2. So now if you are giving vaccine to an Indian population in June, July onwards, we will be giving this southern hemispheric vaccine. Now, fortunately, there is no change, but suppose there is change in a northern hemispheric vaccine and he is going to a country and going to stay in a country where there is a northern hemispheric predominance, you'll have to tell them this vaccine will protect you as long as you are here. But once you go to America or wherever there is a northern hemispheric vaccine, take that northern hemispheric vaccine as an additional dose, if there is some change. That was another point. IPV schedule don't follow CDC guidelines. Our guideline, our is 6, 10, 14, 18 years, 18 months and 5 years. So that has to be followed. Then the polio is the most, I can select only 2 virus vaccines where the suggestions are required. One will talk about the yellow fever. Yellow fever vaccine, you must know the guidelines with the different countries. And if somebody is coming from that country to your country, still they have to show a yellow fever vaccination status. If it is less than 6 days, then they will be detained at the airport till 6 days are over. If the person is asymptomatic, then only he is allowed. The same thing will happen for us. There are few countries like in African, South American countries and African countries. Like Kenya, Tanzania, there are so many countries where you are supposed to take a yellow fever vaccine and 10 days before your journey. And one change in yellow fever vaccine is now once you get 1 shot of yellow fever vaccine, it is lifelong. Initially, it was for 10 days. So this is very, very important because so many people are going to Kenya, Tanzania, South American countries for during their holidays. So it is mandatory. That you should not forget. Another most important thing is polio. Though it has been eradicated from our country or so many countries, there are two countries in the world, Afghanistan and Pakistan. They have got wild polio virus circulation.
Yes.
But there are few more countries where there is CPDP circulation.
Yes.
So Kenya, Somalia, then Republic of Congo, there are so many. So now the recommendation, recently one of the patients sent me this, that Indigo has made it mandatory for him to take polio certificate. The WHO says, if you are traveling to the country where there is a wild polio circulation like Afghanistan and Pakistan, or the countries where there is CVDPV circulation like Kenya, Somalia, Republic of Congo, and there are so many other countries, there are 6, 7. So you have to take 2 drops of oral polio or 1 shot of injectable polio at least 4 weeks before your journey, not more than 12 months. So it should not be more than 12 months old vaccination. You take that vaccine, then only they will allow you to come inside their country. That is not only for your protection, even for them, they do not want to take a chance because they feel that these countries might be having CVDPV. So this is a new thing. So somebody traveling to Kenya has to take 2 certificates. One of yellow fever, so yellow card he has to carry, and another certificate from the government authority as far as the polio vaccine is concerned. If somebody is coming to your country, again the same rule, they have to show that certificate, and at all the borders of our country, the medical officers are sitting there, they will give you 2 drops of oral polio to all these people who are coming from outside, especially for these countries. So this is another important vaccine you should tell. Then as far as hepatitis A is concerned, in our country, we ask them to take vaccine after 1 year of age, not 2 years. So we ask them to take 2 doses of inactivated, 6 months apart, or 1 dose of a live vaccine. Hepatitis A vaccine can be given to a child who is 6 months to 11 months also, if there is an endemic hepatitis A in that country. But it is again not counted. So CDC says, so you can use this CDC guidelines here.
Yes.
Somebody, a child who is 7 months old, 8 months old, you can give hepatitis A, do not count it.
Yes.
Only for a short period protection, because immune responses, we are not very sure. Immunodeficient people, or those who are less than 1 year where the vaccine cannot be given, then hepatitis A immunoglobulin has to be given. Then they have said, for 1 month you have to give 0.1 ml, for 2 months you have to give 0.2 ml. The general recommendations are 0.2 ml. That is one. If you are giving it to an immunodeficient person, then you have to give immunoglobulin as well as the vaccine. Rabies pre-exposure prophylaxis in our country, there are 2 doses. The NCDC still says 3 doses. The WHO, the CDC, the ACVIP says 2 doses, 0 and 7. Those who would like to follow NCDC guidelines, 3 doses, no problem. Cholera, you said no vaccine is available. The cholera has got very specific indication. Somebody is going to say for Kumbh Mela, or if they feel that there is a lot of gathering of 100 or thousands or lakhs of people, where there is a possibility of water and food contamination and you can get outbreak of cholera, the Shankol vaccine is available, which is injectable oral vaccine.
Yes.
After 1 year, you can give 2 doses, 14 days apart.
Yes.
And at least 1 dose should be given 14 days before you visit that area. So this Shankol is sometimes available. I think it is from Sanofi Pasteur.
Yes.
So it was available in Nagpur also a few days back. For quadrivalent meningococcal vaccine, this is another most important vaccine where very frequently the students will ask. If a student who is around say 17, 18 years is going abroad for an further education, you have to give 1 dose of quadrivalent MC. And in Western world, in America, they give 2 doses, one at 10 to 11, and after 5 years they again give, because they have got maximum disease burden during adolescent age group. Whereas our recommendation, we can give to a specific individual, not to everyone, not a routine vaccination. You can use Menectra from 9 months of age, 2 doses. And if you are using Menveo, the permitted is only after 1 dose after 2 years of age. So it has to be very specifically given. If somebody is going to an African country where meningococcal infections are rampant, somebody is going to Hajj, somebody is going for higher education, you have to give specifically 1 dose as per their requirement. And then what you said, if it is less than 7 years, 3 years booster, if it is after 7 years, 5 years booster, that is perfect. These are few things which I thought I should elaborate from your side. And for any advice, you should know what is the immune status of an individual. Means whether he is immunocompetent, whether he is immunodeficient or immunocompromised, whether he is on any medicine like steroids or immunomodulating drugs, and what is his immune status before you advise him something. He is already protected, you do not have to give all the things. So you have covered and discussed all the vaccines, but such suggestions may not be required for him. So you should ask for this. I think these are the points which I thought I should highlight on this.
Yes.
If there are any queries from your side, we will be very happy to answer.
Thank you, sir. We will take the questions at the end.
Yeah, absolutely.
Now, may I request second presenter, Dr. Nitin?
Yes, ma'am. Good evening. I am sharing
Yeah,
the
good evening. Yeah, please share your slides.
Are my slides visible, ma'am?
Yes, sir. Right.
Good evening, everyone. First of all, I would like to thank IAP and IAP Raigad, Dr. Nimain Mohanty sir, Dr. Umesh Kadane sir, and Dr. Chitra Kulkarni ma'am for the encouragement and opportunity for this journal review. The topic of the journal is levetiracetam and midazolam versus midazolam alone for first-line treatment of children with generalized convulsive status epilepticus, a randomized control trial. This article is published in Indian Pediatric Journal on 15th August 2023, volume 60, 8 chapters, page number 630 to 636, with an impact factor of 2.3 at 2022. The corresponding author being Ahmad A. El Shatter, Faculty of Medicine, Department of Pediatric, Sohag University, Egypt. Introduction. Generalized convulsive status epilepticus, GCSE, is the most frequent pediatric neurological emergency worldwide and associated with significant morbidity and mortality. Benzodiazepines are the first-line anti-seizure medications for GCSE. However, benzodiazepines fail to end seizures in a third of cases, that is 1/3 of cases. Combining benzodiazepines with another anti-seizure medication might be a potential strategy for rapid control of GCSE. Levetiracetam, being a broad spectrum anti-seizure medication with a high safety profile, is preferred choice for combination with benzodiazepines in the initial treatment of GCSE. The objective of this study was to evaluate the efficacy of adding levetiracetam to midazolam in the initial treatment of pediatric GCSE. This study is double-blinded, parallel, superiority, and placebo-controlled trial, which was done in setting of pediatric emergency room at Sohag University Hospital, Southern Egypt, in the duration between June 2021 to August 2022. It included children between 1 month to 16 years of age, presenting with GCSE lasting more than 5 minutes duration. GCSE is defined as clinically observable generalized seizures that are continuous or recurrent without regaining consciousness between seizures for more than 5 minutes. The excluded children exclusion criteria was traumatic brain injury, end-stage kidney disease or severe liver disease, cardiac disease or hypo or hyperglycemia, known mood or behavior disorders, prior anti-seizure medicine for this particular current episode of GCSE, regular levetiracetam therapy already, or allergy or contraindication to any of the study medication or lack of IV access. Materials and methods. Interventions. It included pharmacy diluted intravenous form of levetiracetam, which usually comes in 100 mg per ml, that was mixed with isotonic saline to prepare a 50 mg per ml concentration. Pharmacist filled the levetiracetam in solution in 50 mg per ml, that is active drug, and isotonic saline, which is a placebo, in a 90 ml identical containers with sealed identification codes. Dose of the study drug is 1.2 ml per kg, that is corresponding to 60 ml per kg of levetiracetam in case of active drug. The recommended emergency measures for GCSE was taken care of as per institutional protocol. Study time 0.0 was the beginning of stabilization phase. Ongoing seizures for 5 minutes. If at all it is there, then IV midazolam at 0.2 mg per kg over 2 minutes was given. Along with that, 1.2 ml kg of the study drug was given as per the assigned group. A second IV midazolam dose was given if the seizure lasts more than 5 minutes after completing the first midazolam dose. And if the seizures are persisting at 20 minutes, loaded with IV phenytoin 20 mg per kg over 20 minutes. And if further persistent, the patient is shifted to ICU and then loaded with another dose of midazolam at 0.2 mg per kg and then started on continuous infusion. The rest of the general care was same as done for the underlying cause, in particular to general medical care, fluids, electrolytes, nutrition, and other conservative management and specific treatment. The outcomes, primary outcome was proportion of participants who achieved a cessation of clinical seizures at 20 minutes study time point. Secondary outcomes included cessation of clinical seizures at 40 minutes and at 24-hour time point. Hypotension, skin rash, agitation or aggression, need for intubation, and mortality. Sample size was calculated based on using data, assuming 70% success of midazolam to stop clinical seizures at 20 minutes time point, which was the primary outcome. And added to that, 20% success for levetiracetam over placebo, keeping two-sided alpha at 0.05 and beta value of 0.2, resulted in 62 subjects per group. Which was increased by 15% for possible dropouts to reach a final sample size of 72 subjects in each group. So there are 4 types of randomization, as we know: simple randomization, block, stratified, and covariate adaptive. Here it was block randomization technique. This is computer generalized random numbers as in permuted blocks of 4 was selected. Then this block randomization ensures equal sample size in allocated groups. Person not belonging to the research team sealed the random numbers into sequentially numbered opaque envelopes. Based on the assigned random number, the the participants are allocated into different 2 groups, either of the groups. Blinding the participants and parents, treating physicians not blinded. And the statistical methods was based on Stata software, and it was intention to treat principle was applied. The data was represented as proportions for categorical data, mean with standard deviation for normally distributed data, and mean with interquartile range for non-normally distributed data. Binary outcomes were analyzed using chi-square test or Fisher exact test. Confounding effect was taken care of by multivariate logistic regression model. Subgroup analysis to compare the treatment effect on the primary outcome among different seizure etiologies was done by using Mantel-Hansel method, and p-value of less than 0.05 was deemed statistically significant. The results, the flowchart shows in initial enrollment, 250 children were assessed for eligibility, among whom 107 were excluded, who one or two patients did not meet the inclusion criteria, and 5 declined to participate. And among those remaining 144, they were allocated equally into 2 groups by the computer randomization method, allocated 72 in each group. One is the drug group that is allocated to levetiracetam, and another to placebo group. And they were followed up, and there was no loss to follow up, and analysis was done on all the participants who were included in the study. This is the baseline characteristic features of children with GCSE enrolled in the study. This, however, these are the two groups: levetiracetam midazolam group and placebo midazolam group. The characteristics of age, male, and the etiology of GCSE, they are all almost comparable with each other in different groups. The response to the study drugs in children with generalized convulsive status epilepticus, coming to the primary outcome, the seizure cessation at 20 minutes showed that 76.4% of the patients, that is 55 in levetiracetam group, achieved cessation versus 69.4% of the placebo group. However, the difference was not statistically significant. If we see the other outcomes, secondary outcomes, that is seizure cessation at 40 minutes, again, we can see 95% of the children have achieved in compared to 91.7% in the placebo group. And seizure control of 24 hours is also slightly more, 84.7 versus 76.4. However, there was no statistical difference, significant difference between the same. To continue with, the seizure cessation of 20 minutes was compared after the study drugs in children with the generalized convulsive status epilepticus. This was done to know the relationship between the etiology, which was febrile seizure, CNS infection, and known case of epilepsy. This also showed that there was no significant difference of treatment effect on primary outcome among different seizure etiology, and Mantel-Hansel test of homogeneity was applied for the same. Multivariate model that included the following variables along with add-on levetiracetam remained not significantly associated with primary outcome. However, there was no, this is the adjusted odds ratio that shows there was no significant relationship between these characteristics along with add-on levetiracetam on the primary outcome of seizure cessation at 20 minutes. So add-on, this study shows that the add-on levetiracetam offers no significant advantage over midazolam in controlling seizure at 20 minute, 40 minute, and 24 hour of presentation. The studies done on adults with GCSE showed no significant difference between levetiracetam plus clonazepam and clonazepam alone. In certain animal experiments, however, that showed potentiation effect, that is levetiracetam with diazepam, even when given in low doses, have got significant improvement in the cessation of seizure. And the study conducted by Mishra et al. Showed that IV levetiracetam used as an initial monotherapy. It also achieved or termination of seizures in 76.3% of the patients with status epilepticus within 10 minutes of completing the injection. So in this study, what could be the possible reasons for low efficacy of levetiracetam, even though it was given along with midazolam in the initial setting itself? It's known that benzodiazepines cause membrane hyperpolarization and suppression of neurotransmission that might have reduced the efficacy of levetiracetam. Also, status epilepticus is known to alter the cerebral expression of SB2 synaptic vesicle 2A protein, which is the main target of levetiracetam, that might have an effect on the response to levetiracetam. And usually the plasma peak concentration of levetiracetam is achieved in 5 to 15 minutes with intravenous usage. However, in this study, if we note, the second dose of midazolam was given at 5 minutes itself. So it was again confusion to whether that was to be contributed to levetiracetam or not, because it was the time that is taken for levetiracetam itself is 5 to 15 minutes. The limitations of this study could be the seizure cessation was evaluated clinically. There was no consideration of EEG confirmation, and the time frame was 24 hours, and that might miss the other efficacy and safety outcomes. Participants, however, mostly in the age group were less than 3 years or more, and etiology mostly was confined to febrile seizure. So that might lack the generalized ability to other age groups and etiology. Add-on levetiracetam may have a smaller effect size than the postulated 20% in the calculation of study sample size. To conclude, add-on levetiracetam presents no significant advantage over midazolam alone in the initial management of children with GCSE. Future research may investigate the use of higher levetiracetam doses, e.g. confirmation of seizure control, or longer study time frame, and a larger and more non-restrictive sample size. And what is already known is that levetiracetam has comparable efficacy to phenytoin, and valproate has a second-line therapy for pediatric status epilepticus. This study adds that combining the levetiracetam and midazolam for initial management of pediatric GCSE has no significant advantage over midazolam alone in cessation of clinical seizures at 20 minutes after therapy. Thank you.
Thank you. Our expert, Dr. Umesh Kalane, is requested to give his expert comments.
Thank you, madam. Thank you, Maha-IP. Thank you, IIP Raigad, Niman Mohinty sir, Chitra madam, for giving us this opportunity to present a very interesting paper actually about levetiracetam. Because this
Would you like to stop the share, Dr. Nitin? Or sir, you want the slides, then we can continue.
It's fine.
Oh, okay.
So levetiracetam has been licensed since 2006, initially for adult and as usual story, then gradually for the pediatric population, and then gradually even being permitted for the neonatal convergence. And it has been used in various permutation combinations with other drugs. And now what we know that it is used as a second line along with our old drugs like phenytoin, phenobarbital. And this is a good paper. What they have checked is in acute management. Now, if you consider levetiracetam, IV availability is good. This drug has very less side effects, not much problem with compatibility with other IV medications. And the peak action is within 5 to 10 minutes, as already Nitin mentioned. So they have nicely randomized this superiority control, so double-blind trial. But surprisingly, the results are not good. So again, it is proven that our old drugs like midazolam, phenobarbital, and these are still efficacious, and we should not jump in using this drug randomly for every case as a acute management. We still require more data for it to use or to substitute midazolam with levetiracetam. Even we have previously reviewed articles about use of levetiracetam in neonates instead of phenobarbital. Now in neonates, first line is a phenobarbital. Many NICUs, they are using levetiracetam as a first line. And we found that still phenobarbital is a very good drug. Sometimes these pathologies are quite different in pediatric population. And sometimes like in the case of hypoxic ischemic insult in NICU, we see that these seizures, they peaked in 1 or 2 days, and then gradually these seizures decreases in frequency over next 2 to 3 days, and then sometimes inadvertently this response is being attributed to the drugs like levetiracetam. So this is a very good paper to suggest that midazolam is still a first-line drug. There should not be one should not be in hurry to use levetiracetam as a first line in acute condition. And Nitin has very nicely mentioned about the possible failures, because the mechanism of levetiracetam is very novel. It acts through this SV2A molecule, which is a receptor for neurotransmitter release. And benzodiazepine hypothetically hyperpolarizes membranes and reduces this neurotransmission. So hypothetically, it might causing antagonist effect for the levetiracetam. And as you know, midazolam acts for only few minutes. So that might be explaining why the same drug after 20 minutes, if we'll give as a second line, is working, but not with midazolam. So that is one possible thing. I'm postulating that it's not working in acute stage with midazolam, but it's working as a second line along with or instead of phenytoin. So this is a good paper to suggest that we need further scientific data for substituting benzodiazepines as acute status management with levetiracetam. So any questions on that? I think he has nicely explained most of the things. We can take that.
Thank you, sir. Pallavi ma'am, any questions in YouTube? Okay, this is a question for vaccine, travelers vaccine, that usually it is said that measles, MMR, and varicella, they may counteract in formation of antibodies if given together. So what is the recommendation, Dr. Sanjay?
See, these are two live vaccines, and live vaccine as a rule can be given on the same day. If you are not giving on the same day, then you have to keep the minimum gap of 28 days. And if I am not wrong, there is a preparation called as MMRV.
Yes.
So when there is MMRV preparation, there should not be any confusion in our mind that both the vaccines can be given the same day, being two live vaccines, and there is no interaction between these two vaccines if it is given the same day. If it is not given, ensure that you are keeping a gap of 28 days.
Thank you. And the difference of recommendations between the Indian chart, our EPI schedule, and that of American, that you can state that what is the difference, which was not explained in the paper.
See, the point is, your immunization schedule is always according to the need of your country. It cannot be a standardized protocol for everybody to follow. See, for a rabies, you might have the same protocol everywhere. But see, our priority is in our population, we have got early infections. So you have to protect that community as early as possible. So what we have seen, even at 6 weeks, we start our immunization schedule, though it is a bit compromised schedule, but ultimately you have to reduce the morbidity and mortality. So we have selected 6 weeks, not because we were very happy with the 6 weeks, but our priority was to protect the infants from getting infection. Our mothers were not protected adequately, so their levels were poor. They were never getting Tdap before. So protection offered to the infant was very poor. So we started giving it at 6 weeks. Whereas Americans, they know that their disease burden is quite less. So for the most scientific way, they have started giving the vaccine first at 2 months and keeping a gap of 2 months, which is more scientific. But we cannot afford it, so our schedule is different. Their schedule is different.
Yeah, thank you, sir. Now, is Maharashtra endemic for Japanese encephalitis?
You cannot just say that whole Maharashtra is endemic for Japanese encephalitis. But there are many cities, almost I think if I'm not wrong, 300 plus across the country. They are declared as endemic to Japanese encephalitis. See, the real issue comes in Nagpur. The Nagpur city is not endemic, but Nagpur periphery is endemic.
Oh.
So it is very difficult for us to say that a person who is staying just say 10-15 kilometers from the heart of the city, he has been advised to take 2 doses of Japanese encephalitis, and with us we say it is not required. So you cannot make it very hard and fast. If your peripheries are endemic to Japanese encephalitis, and if you offer Japanese encephalitis, it's a very safe vaccine, can be given very comfortably, there is no issue.
Yeah, so we have to advise whenever.
You have to advise accordingly. If somebody says he would like to get protected, there is absolutely no issues. You can give the vaccines and protect.
Right, right. Sir, many of the times we have seen that the senior citizen going abroad, they were previously advised only Tdap, but nowadays they are advised Tdap as well as oral polio. So should we advise them IPV or oral polio?
See, that is called as cocooning. If you are talking about the
Yes.
See, cocooning was basically to protect the individual who is not immunized adequately till that period. Suppose a newborn baby is there and the parents or the grandparents are going, or some relative is going to help them, then he should be protected at least from the diseases for which the newborn or an infant is not protected. So they started with the flu shot, then they added Tdap, then they will say COVID vaccines, whether you have been protected adequately, otherwise do not come. So now the oral polio is indicated if you have got there are two indications to give oral polio or an injectable polio, either or. It is, but now standalone IPV is not available. So from where you will give IPV? So only way is to give oral drops, and that to when bivalent OPV is available. So now the indication is if you are from a country either having a wild polio virus circulation like Afghanistan or Pakistan, or you are a country listed where there is a circulation of CVDPV. These countries, if you are anybody from these countries is going to the polio eradicated country, they will ask for 2 drops of oral polio at least 4 weeks before their journey. That is the new indication which has come in WHO paper also.
Yeah. Thank you, sir. Dr. Sanjeev Joshi has raised hand. Sir, please unmute and ask your question.
Just quick comments about that second article. The Midas and levetiracetam as a first line anticonvulsant for status epilepticus. I think there are so many fallacies. If Dr. Kalane will also agree with me that the EEG correlate is not there. So you don't know whether there was electrical cessation of the seizure or not. Another thing, the endpoint is taken as 20 minutes. So by that time, if levetiracetam has to act, it has already been acted as a second line, but not as an acute one. But the most important take-home message, all the participants should receive that levetiracetam is not the first line drug for controlling acute seizure. It is the benzodiazepine, and it has got level A evidence. And even in a pre-hospital setting where there is no any IV access, or at a home setting also, the non-IV midazolam like the buccal, the intramuscular, and the rectal, it has also got level A evidence to control acute ongoing seizure. This is as per the latest evidence from the American Epilepsy Society. So please don't use levetiracetam as a first line drug in any setting of controlling acute seizure. Another fallacy in this paper was the distribution of provoked and unprovoked seizure was not clearly demarcated. Your comments, Dr. Kalani.
Yeah, actually, when we read this paper, we discussed among ourselves that they have excluded traumatic brain injury, severe diseases. In fact, if you consider use of levetiracetam, the most talked about levetiracetam is the less interaction with other drugs, so-called less side effects. So in such scenarios, we need some drug which will have less less interaction with other drugs. So in per se, levetiracetam in such scenario we use quite often as a second line, not as a first line. But in this paper, they have excluded all. Even I don't know why traumatic brain injury cases were not involved. But I can understand the problem with these studies. See, these are pediatric emergency research. So in pediatric emergency research, there are various problems like even taking consent. It's not possible to take consent in such scenarios. So they have tried a very good study. That's why I told 72 is a very good number, and with the difficulties. But already the paper itself is telling that there is not much role of levetiracetam as a first line. And the second thing, for the pediatricians, levetiracetam, if you calculate, is not that cheap drug. So many times, even our neurosurgeons, it's a favorite drug for them. Everyone is kuch samajh mein nahi aaya, they start with levetiracetam. So don't do that in acute settings. Still, as Joshi sir has already mentioned, benzodiazepines still the gold standard.
And even in a pre-hospital setting, if you are struggling with an IV access, there are very few things, Dr. Kalani, if you are agreeing with me, that a level A evidence for non-IV midazolam for acute control of seizure. Yes. So use more, you should encourage the use of Midas nasal spray. Even the injectable preparation can be used as a buccal one. And the base route in an emergency setting is an intramuscular, but the dose is 0.2 milligram per kg. That's all, one way.
Yeah.
And Sanjay always
Yeah.
very comprehensive and very deep discussion. Sanjay, thank you.
Thank you. It's a
Thank you,
pleasure,
enlightening
Sanjeev.
us.
Always a pleasure.
My question to Dr. Umesh sir is this drug Livera is as such very good drug, and you should give a clear take-home message to the practicing pediatricians when to use it.
Then it will be a little out of journal. Because that's why I was
The main,
restricted my
main,
talk for the. No, I will tell.
The main
My
reason
talk was
to take this topic is to discuss for this only.
My first message we have given clearly that it's not an acute drug. So now we can discuss. Levetiracetam per se is a good drug, which is in acute in status. We use as a second line. Along with phenytoin, we can use as a second line. Even as a third line, we can use. IV medication, it is available IV. Many brands are there. So now it's available in peripheries. Initially, we used to struggle to get these medicines in peripheries, but now it is easily available. Second thing, oral formulations have been studied with IV. They are also equally good in terms of bioavailability and the efficacy. Again, these drugs are available as oral, tablets, syrup forms. So easy to administer small kids, like we have valproate. So levetiracetam is also a broad spectrum. Again, it can use in focal as well as generalized epilepsies. And in pediatric population, we see a lot of epileptic encephalopathy, channelopathies. In many such cases, levetiracetam is a useful drug. So definitely one can use in a maintenance epilepsy cases. Levetiracetam as a first line or as an add-on. It's a broad spectrum. It can be used in focal as well as generalized epilepsies. It can be used in epileptic encephalopathies as well. Okay, so this is my message.
I think in a single word, in an acute control of seizure, levetiracetam has got its role in a benzodiazepinized patient. Okay.
Yeah.
Who has received already benzodiazepine as a first line drug, and then if at all you need a second line, then there is a scope for levetiracetam, but never as a first line.
Perfect.
Even in you have.
Perfect, sir. The question for Dr. Sanjay Marathe is, up to what age we can give JE?
There is no upper limit. The routine recommendation is for up to 15 years in our purple book. But now even the adult vaccination they have started. So if you want to protect somebody, you can use it even in adults. There is no issue. But routinely we do not recommend for them, because over the period of time, if somebody is staying there for 15-20 years, they must have got some protection because of the frequent exposure to the same infection. So routinely we do not advise, but if there is an outbreak and all that, we can certainly give to anybody.
Yeah.
So there is no upper limit like this.
Yeah. Thank you, sir. Now may I request our mentor, Dr. Nimen Mohanty, sir, for the comments on these two articles.
Thank you, Dr. Chitra. Both the presenters have done very well, and after the kind enough to be here and dispel all the doubts. One information I would like to add that our Raigad district has also entered the endemic zone of Japanese encephalitis. It was proven in our MGM, and this virology National Institute of Virology Pune confirmed this viral detection, and the government had declared that it is a doctor. They said the person who is going abroad, he is all right, he should comply to the vaccination schedule of our country, but where he is going, that legal requirement he should comply. Ideally, if that is possible, should see that he complies to the requirement of legal requirement of the place he is going to visit. That is also it kept in mind. And little variation in our immunization schedule. Dr. Saab has brought out very well, like at birth polio, nowhere it is given. But here it is given. It's a logistic issue that we are scared. Even during those newborn period, there is a chance of the baby getting infected with polio, or so much rituals and so much goodies there is a chance. So we use to be very sure about the protection we use in the birth dose zero polio. So that's it. Otherwise, our country, we are conscious of our need and should continue our national program as it is notified to the government. But at the same time, when the person is going abroad, why we selected this topic? This is nothing to discuss the immunization. But our pediatricians should not feel shy when suddenly a person going abroad approaches them in a rural area. I'm going abroad. I want to get vaccinated. So we are lost. We have to refer to the books. These are the Google, Dr. Google have to guide us. That's the problem. So to sensitize our pediatricians, possibly all over the practicing pediatricians, who had selected this topic, and both of the presenters have done very well, and the across the table they have passed the message. Thanks.
Thank you. Thank you, sir. And Dr. Prachi Shirbhate has raised her hand. Doctor, you want to ask some question?
Yes, ma'am. Thank you.
Yeah.
Ma'am, I wanted to ask regarding Japanese encephalitis vaccination, that as sir said, in Maharashtra, all cities are not endemic. Few cities are endemic. And accordingly, vaccinations are there in routine vaccination, like in Amravati, J vaccination is included in routine vaccination. But in other cities, like Pune, Marathwada region, JE is not included. What if we are traveling there with our children who are not vaccinated for JE? What should we do? Do we follow the guidelines given for endemic area traveler for country wise? Are we supposed to follow the same
Dr.
guidelines?
Prachi, clear-cut guidelines are given in our purple book as well as ACVIP. It says very clearly, suppose you are occasionally visiting a place for a day or two, and to a district where you are going to meet your relatives and all that, you are not going to get Japanese encephalitis because that area is called as endemic for that. So it says, just to reduce the number of vaccination unnecessarily, we say if somebody is going to stay there for more than 1 month. Secondly, suppose you are going to in a village or in a forest area where or your job is something like you are likely to get exposed to the mosquito bites more frequently, then you are supposed to take protection against the Japanese encephalitis. Sometimes suppose you are traveling, suppose I am taking a train journey and I am crossing Amravati, which is an endemic for Japanese encephalitis. I do not have to take protection against Japanese encephalitis because my train was at the railway station of Badner or Amravati. It is not like that. So if you are going to stay there for a longer period of time, or your job which you have taken is definitely you are likely to get exposed to the mosquito bite and the Japanese encephalitis virus, then you are supposed to take the protection. That is basically to limit the number of unnecessary vaccination. But then in a Japanese encephalitis, sometimes it is very difficult to explain that in city it is non-endemic and in the periphery they are endemic. So how to explain that my patients will never go and stay 15 kilometers? So, but then you have to follow because it is still not a routinely advised vaccine, but a very safe vaccine. If you give it, there is no harm. I know a couple of pediatricians are giving, even if it is non-endemic city, they are giving Japanese encephalitis. I think it is better than giving an quadrivalent MCV to everybody. So at least do not give quadrivalent MCV to everybody only because the vaccine is available and it is safe. But you can give Japanese encephalitis, no issues.
Yeah. And can be given
Thank you,
in
sir.
the same sitting.
With any other vaccine can be given. but 2-dose schedule after 1 year of age.
Yes.
Okay.
We are coming to the conclusion of the program. Very nice program. And let me do the privilege of Thanksgiving to this August gathering. Thanks Maha-IIP President Dr. Ram Gopal, Secretary General Dr. Amol Pawar for giving us opportunity to present here and to address 200 plus delegates virtually on this platform. I also thank Raigad. Yes, sir. Raigad.
बऱ्याच लोकांना काय सरीचं हेच करता येत नाही, अलाइनमेंटच नाही करता येत. मी आता केलं अलाइनमेंट 8 दिवस पण नाही झाले.
Please mute Vikas More and
ते काय करतात ते व्यवस्थित लट फिट करतात ना, तेवढ्या टायमात ती सेटिंग बिघडून जाते.
May I request to mute?
Ma'am, done. Ma'am, done.
Yeah, thank you. Thank you very much. We also thank our mentor, Dr. Nimel Mohanty, who is frequent visitor to MGM library and painstakingly finds out the topics each month for us, which is very helpful in practice point of view. Our experts, Dr. Sanjay Marathe sir and Dr. Umesh Kalane, unke to kya kehne. The best experts we got, and those who are interested in their topics. Our presenters, Dr. Nitin R and Dr. Balakrishna, for excellent presentation and conveying our message from the review article as well as research paper. Our backup team, Dr. Neha Singh and Mrs. Pallavi Dharmadikari, a big thank you. Thanks all. We may stop the recording now, Pallavi.